ready? You got me running.
I am Meredith Hirsh, and this is Working Healthcare. If you try to be negative with my next guest, I promise you she'll flip it around. She is GA from the VA, otherwise known as Georgia Bonney from Virginia. She's my friend and collaborator on the management side of medicine. Georgia started her career as a medical assistant, but quickly realized that she could help patients more by being on the management side of healthcare. Georgia has worked in GI, primary care, dermatology, and rheumatology. She's a key contributor to healthcare management organizations and has a really funny side, too. If you want to learn the upside of healthcare in America, stay tuned. Georgia Bonney, welcome to Working Healthcare.
Meredith, thank you so much. It's my pleasure.
I love the fact that when I first met you, you said, you can remember me. I'm GA from the VA. So you are GA, Georgia, from the VA in Virginia. So what are you doing up in Virginia? Have you always lived there?
I'm originally from Texas. GA from the VA is my opener, a way to break the ice with any new people I meet or any presentations I do. It's a good tagline. My teenager is the one that gave that to me years ago, and I just keep using it. And you know what? It's a good one because for someone like you to remember that, I've met the mark.
So it's Georgia, and your mom is not American. You're actually first generation. You have an immigrant mother. Why Georgia? Why did she? I love the name. I love the state, but there has to be a story behind it.
Well, actually, my dad is from North Carolina. My mother is from Portugal. Came to the U.S. with absolutely no English. How her and my father communicated is amazing to me. She could not drive a car until she was around 42 years old. And she thought, and when my dad suggested the name Georgia, that it was actually for the country Georgia, not the state of Georgia.
That is interesting. Yeah, I guess I could think that. I hear about Georgia a lot from my son, who's the winemaker, because the first vines actually started in Georgia. Did you know that? The state, right. not the state, the country, not the state.
Georgia, as my mother would pronounce it, is Georgia. It's not Georgia.
She says it much better.
And Georgia was the way, and she would yell it from anywhere in the neighborhood. You could hear my mother yelling my name, calling me into the house from playtime. So I do think that it's impactful for me. Having an immigrant mother, I'm first generation college graduate in my family, which I'm very proud. And I take a little bit of my American side of the family and a lot from my Portuguese side of the family and the way that I just live my life in general.
You didn't start actually your career with a college degree straight up. You actually started out as a medical assistant. You became a radiology technologist, and you thought you were going on the clinical side, but you pivoted. I'd love for you to share your story because, yes, then you became the first college graduate in your family. Why did you make that pivot?
Well, you know, as any young adult nowadays, and even decades ago, I didn't know what I wanted to be when I grew up. And our wise family physician had said, hey, pick anything in healthcare. You'll always have a job. So my parents spoke to me and they said, look, you know, why don't we have a decision? As you know, in multicultural families, it's a decision for the family, not just the individual. And pick anything. It's a good place to start. Get your feet wet, look at the professional careers in healthcare to see what could happen. At the time, radiology technologist was a 2-year associate degree through the local community college. So A, it was affordable, and B, it was a pretty straight career path. Back in Virginia in those days, there was no licensure, so I had a job waiting for me my first month as a radiology technologist student and kind of learned on the job and through the program. And while I loved all the clinical exposure, what became apparent to me very quickly was that there are real gaps between policies and practice in healthcare. And for me, within the first 12 months, I knew that I would put myself back to school I went to night school for another 2.5 years while working full time to get my health administration degree because I thought and I knew I could make more effective change.
Do you think that you needed the education in order to go the management track in healthcare?
I don't think that everybody needs it. I do feel like it's a core foundation for me with labor law and administrative processes that would have a pretty steep learning curve without it. I have met some really great, smart, and wonderful managers who do not have that degree, and they do fine, but it's a lot more trial and error and a lot more networking and a lot more research that goes in. And I think it just gave me a better foundation or jump off point for me to accelerate my career in management.
Why did you even want to go into management? And I ask that because I mean, to me, you're a natural in that world, and I've only known you in that realm, and we've known each other for, I don't know, 7, 8 years, maybe. Do we go back? At least,
Okay.
GA from the VA, at least 7 or 8 years. One of the key people within our practice actually started out in radiology technology as well. She was an RT, Shelley, who I'm sure you know, and she quickly knew that she needed to go down the management track because so I keep thinking, I need to just keep hiring RTs and then I'll develop them into management. But why did you realize that you didn't want to be on the clinical side anymore and you wanted to move into the management world?
Well, I enjoyed the patient time. I went through RT back in that time frame in the 80s and early 90s was I did regular diagnostic radiography. I did surgical assistant with radiology, ICU, emergency room. For me, as an 18-year-old, it was semi-traumatic for some circumstances, emotionally immature at that time, but a lot of exposure. And I just felt that even though I had exposure to different parts of the hospital system, I wasn't having any stable congruency. And again, 20 layers of supervisors didn't make sense to me. If I could report up a known problem, and when I would recognize maybe an operating procedure should shift, that it and 20 other people recognize the same problem, that it just took so much change and effect for it to finally become a revamped process in that setting. And hence I went through management. Now, the local college here, Old Dominion University, takes working for healthcare professionals such as RT, nursing, any of the technologies. They have a curriculum that brings in your education for those programs into a 4-year degree. So I walked in halfway through a bachelorette with my existing associates that I had, and that made it much easier. And at that point, you really could navigate any type of healthcare administration job you want. And I gravitated towards small practice. That's what I've always had the most at.
And you were very passionate about independent medicine and helping those physicians. What was different about the hospital arena versus that small practice that really drew you?
I think the first core metric for me is that I believe in the physicians that I've always worked for. And in bigger healthcare settings, time and again, I saw that they were stymied or restricted in how they could treat their patients, not just from the time they could spend with them, but the treatments they could order for them, follow-up times, and it just felt a little bit more micromanaged than I believed a provider should be. When I first went into private practice, I saw that we could really make some impactful change. I think providers stay in private practice because they want a work-life balance. They want to be masters of the domain, and I 100% buy into that. But I also feel that most physicians that I've worked with through the years are not great business people, although that is getting better, and most of the physicians I work with now are definitely more savvy in the business aspect.
But don't you think they've been forced to be that way, Georgia?
I think they're forced to be that way, and the response is, A, I'm burned out and I don't like the HR and administrative piece, or I can't do it well enough, so they may entertain private equity or going back into a healthcare system. Or they say, okay, I'm going to learn this, I'm going to figure out best practice, and then they can be successful. So there's a splintering of the guard, per se, when it comes to private practice. And I'm not sure about the influence and the mettle of each physician as they decide to do it, but I'm seeing a lot of movement. So if you had asked me 5 years ago, what is happening in rheumatology, for example, with private practice? And I said, I have some serious concerns over the next 5 to 10 years about longevity of private practice. But as we have more advancements in AI and technology and ability to restructure the way we run our businesses, I am seeing a fairly good number of rheumatologists coming out of big health systems and opening their practice. And so I now have more hope and better hope for the next decade in the specialty.
And I'm seeing that a lot. And I'm going to use the example of Carlene Sue, because I had Dr. Carlene Sue on the podcast probably over a year ago at this point. And she worked for a larger health system, and she, as you had stated, wanted more autonomy and control over her practice, how she took care of her patients, what she was able to do. And so she went out on her own and she started the Rheumatology Private Practice Alliance so that independent rheumatologists could all get together and discuss challenges that they're having, come up with solutions together, and really form a community. And it's phenomenal. And you're right. About 5 years ago, you're starting to see those who were hospital-based or those who are in larger facilities trickle into independent practice. You had said that you think that these doctors are saying, hey, I want more of a work-life balance. But I'm going to question you on this. I don't think you have more of a work-life balance when you're in independent medicine, because I think you work so hard and so much harder. I think that you have more control. Would you think that as well, or do you still think that there's a better work-life balance in independent medicine?
I believe there's a better work-life balance in independent medicine because my exposure is to all the wonderful physicians who are doing this day after day, that having given up, that are not going back into the bigger industry. And while I don't see that as a negative, and I feel like it's a good fit in the same way that I feel like private practice is not a good fit for every administrator, but it's my exposure, right? We live what we know. And I just want to mention, like, when I came into rheumatology, I had no idea what rheumatology is.
Yeah, you didn't start in rheumatology.
I did not. I have done a number of specialties. I've never had a favorite. Internal medicine was my standard for over 13 years. I came into rheumatology not fully understanding the specialty, and in my first 6 months, I was ready to run away.
Why?
Because I had never lived in a healthcare system that required permission for every single patient treatment. Every single one. I have never had to learn so much about prior authorizations and mother may I from all the payers. I had never truly understood utilization management until I came into rheumatology.
Describe what utilization management is.
Utilization management is the vehicle in which insurance companies use to control treatments of patients solely based on their financial aspect to them. So it's for their financial control. And as such, they will limit the number or kinds of medications that patients can be treated with. And when a physician wants to order that medication for a patient, the provider office must submit a prior authorization and jump through numerous hoops in order to get it approved for a patient and on their behalf. Significant time delays, denials, lack of care and treatment, and poor outcomes are really associated with prior auth denials and delays in rheumatology.
So you didn't start in the rheumatology world, but I would say we didn't have the mother may I issue until probably about 2003. And this was before my time, but it's when all of the complex biologics started coming into the system and the medication became so expensive. Did you see this happening with other specialties?
No, the most I had ever bought and billed prior to rheumatology 15 years ago was childhood vaccinations, MMR, polio vaccines, very minor costs. To age myself a little bit here, we had paper schedulers. We had, they were massive. We used a highlighter to check people in and out. We wrote in pencil. I wrote paper ledgers and statements when I was sending out patient billing and claims. There were absolutely no deductibles except for TRICARE at the time, or Champus, as we called it then, had a $50 deductible. Zero copays were in existence. And my, oh my, how life has changed. It's changed the way I train my front desk, the way we are concierge, staff members, treatment planners, in order to provide and deliver good access to care to our patients. The discussions have totally shifted. And we spend at least 30% of our time in this practice this time of year just trying to navigate insurance changes.
Oh my gosh. Yes, benefit verifications.
Right.
And do you hold medication for a block of time? We do, for 10 days from the beginning of the year, not for our original Medicare patients, but for all of our other insurance patients, because we have to re-verify their prior authorization or their insurance information, which ends up delaying care.
That varies. We've gotten a little bit better about not restrictive. We were delivering infusions on January 2nd
that's
this year,
great.
the earliest ever. The delay becomes part of the payer issue. If the payer can't give us back a re-verification of a prior auth, and that can create a delay. We do give a lot of notice to our patients on how we work on their behalf. 15 years ago, I said, let's just do the work. We're not going to bother patients with all the detail. It can be stressful. But now I think it's important to let our patients know along the road what we do for them and on behalf of them in order to deliver the care and medication and treatment they need. In my office, there's an average of 4 to 5 people working on every patient medication throughout the process. And so we're wanting to make sure they're not stressed out about their treatment, their due dates, their bills they may have, and we even helm all the manufacturer support programs for them because we don't want patients to be stressed about the financial burden. That has taken me 15 years in rheumatology to make sure we're doing that process right. And just when I think I have it figured out, it changes. So it's an evolution. It's a continuous care cycle as far as biologic therapies in the practice.
Well, I'm glad you figure it out by the time it changes, because I feel like I'm in the middle of trying to figure it out and it's already pivoted. Do you think the responsibility is solely on the insurer, and that is why we experience these delays or why we're always playing whack-a-mole, or is it attributed to some other factor?
I think there are multiple factors. So the outside influence, of course, is the payer that we're dealing with, the patient. As you know, every state has a Blue Cross Blue Shield plan. Generally now, over half of those plans in each state are self-funded employer groups, which can dictate their own coverage and policies, including exclusion of care for our biologic patients. The interior factors that affect prior authorizations are broken SOPs, or standard operating procedures. Who is working on them? Do they have the time to work? At this time of the year, when you have to re-verify almost 100% of all your patients, is there multiple team members that can lend into that? Are we using third-party vendors? What's their turnaround time? And sometimes it could be manufacturer support programs. They could be delayed in re-verifying millions of patients across the U.S. And so there are a number of factors that are going to influence that. I think inside of each practice, we can just line our ducks up in a row in the best way possible and just be flexible enough in the process to know when to open and close the levers, so that we can make the best decision for the patients without impacting them in a negative financial way.
If you're hiring 5 people to help with the verification process, how does that get paid?
Well, not all 5. Is that their sole job? I'm a big believer in cross-training. I think I'm an effective manager because I can do almost any position in my office. I actually love to sit in and watch so I can understand if the process has changed, how we can make things better, how can we utilize more technology or changes in our EMR. And so cross-training is really big for me inside of any practice that I'm helping with. And what can we lend in? So I do have one full-time bio coordinator. I'm also a biologic coordinator here in the practice. And as needed, I have a biller and 2 medical assistants, as well as my infusion nurses who are knowledgeable about the process. And so we share the wealth of experience and tasks.
You definitely do, especially within a smaller practice. Do you think hospitals are at an advantage, though, because they are so large? There is an economy of scale, and so they are able to hire specific roles for all of these people. And how does that impact independent medicine? Because, hey, if you look at how hospitals are reimbursed, they get about 3 to 4 times the amount than we do in Part B physician services.
Absolutely. I don't think it's apples to apples. Hospital healthcare is completely different. You cannot parlay it to the private practice. Inside of the big health system, they have pharmacists and pharma techs. They're dealing with a lot of pharmacy benefit drugs and the enhanced benefit of being a 340B hospital. So their potential loss is not even comparable to what it could be in private practice. So I don't ever put them in the same bucket. I know that that system is built a certain way, but they're also financially buffered in a way that none of us in private healthcare will ever experience, unfortunately. And I think no matter what we're delivering, right? So if I'm working for a rheumatologist, and my main rheumatologist is Dr. Brenda Dixon here in Virginia. And the one thing she's done with me from the beginning is allowed me to do my job. And in allowing me to do my job, I can keep my eye on the right things to make sure we have the positive outcome. Now, that policy and strategy of prior authorization and access for our patients has shifted every single year over the last 15 years. But I'm committed to keeping an eye on that, and my staff is trained to be flexible enough in those changes. So we feel good about what we're doing. The other impact of this that I think sometimes we don't consider when we look at private practice and major healthcare systems is that the payers do not want the patients to receive these therapies in the hospital setting. As you know, hospital settings charge facility fees. They cost that payer a lot more money. And payers like Blue Cross Blue Shield have come out and said, you cannot refer a patient for that treatment at the hospital. And so now I'm watching to see what the effect is of when those hospital systems are having to push the patients out of the health system to a non-facility based location like a private practice. For example, Cigna.
And not even the private practice. I'm thinking home health. How many times have we received denials for patients to be able to administer the medication within our facilities, and we're getting rejection saying, no, we're going to send an LPN to go do a home infusion, and that's the best course of treatment for the patient?
That's a financially driven decision. I have had that pressure inside of my practice twice over the last 4 years. Payer was wanting to mandate. They did a full market campaign direct to patients about how wonderful it would be to receive their infusions at home and how convenient it would be for them. And in order to do so, their next phase was to reach out to us in the community and say, we want you to sign the infusion orders over to us. We'll take over the home health. When I did a little digging, I realized that the payer actually owned a large percentage of the home health company. Mm-hmm. And so they were routing the funds back to themselves. And then when we declined to switch our orders and of course, having discussions with our patients on why we are required to have a physician on site, but the home health strategy did not, and expressed our concerns with that, the payer demanded that we explain the reason why we would not approve those home health infusions. And the only response I could give them was I first needed them to provide to me the clinical reason why they should.
I recently had Dr. David Kenningsberg on the podcast, and he's an electrophysiologist and cardiologist for those who are unfamiliar. And he started his practice the same year that Mark and I did in 2007. And he just sold to a large private equity group a year and a half ago. While it is physician run, it's backed by a private equity group. I'm seeing this in ophthalmology. I see this in GI. Oncology years ago went through this. We saw it in primary care, right? Dermatology. I'm not seeing it in rheumatology yet. Now, I have met with several rheumatologists who have left the Northeast, primarily Connecticut recently, and moved down to South Florida. And they said that it's very difficult to find a Connecticut-based independent rheumatologist. Most of them are affiliated with the hospital. Haven't done the research to validate that, but they said it's very far and few between, and clinics like ours don't exist. But at least when I go to our national conferences, I'm not seeing private equity. What about you?
There is private equity in Virginia, a company called Privia. I don't think it has hit rheumatology in the way that it has other specialties. I don't have a ophthalmology group that's not impacted by private equity in my area, as well as GI, gastroenterology. Dermatologists are holding steady, but they're consolidated in much larger groups. Rheumatology is unique, and I will say that they're going to be the last forefront in private practice, either single provider or small specialty. And in the eyes of CMS, that's 15 or less providers, which almost all of us are. I think you may see more expansion or associated community practice maybe joining together, such as Sarah in Georgia. And I think that gives some protection. To me, the biggest downfall in rheumatology is our inability to negotiate good fee schedule pricing. There's individual credentialers that have some success with some payers, but as a whole, we just don't have the footprint in the community with the covered lives we need to negotiate. And that is the one downside, and that essentially makes it where we need to see more patient volume for the same money year over year. Add in inflationary issues inside of healthcare in general, and we're all racing towards this finish line that keeps moving on us. But I still think every rheumatologist I know, our discussions are never about population health, because in this specialty, we know that. We know what population health means in rheumatology. We know that we want a triple aim, better health care, good outcomes, patient experience. But every single rheumatologist I've ever worked for just chooses their patients one patient at a time. It's adverse to the discussion of patient population. They understand that, they feel that, but they're the single specialty that says, I want to just meet my patient where they're at individually. And they really do feel if I can make one patient better at a time, that population health stuff is going to come along. But how do I make this happen in my office? How can you help me? These are the conversations. How can I help them streamline processes so they can work better, so their staff can have a better work life, so everybody can share an achievable goal that's not making everybody burn out. So this is what I'm choosing in 2026. And I do, again, have a lot of hope for private practice rheumatology. They are not my only specialty that I'm consulting with, but it is the mainstay of my consulting business.
Because I see a lot of rheumatology groups wanting to align with MSOs, managed service organizations. I just had Dr. Nihad Solomon on the podcast, and we talked about his desire to create an MSO type group. And they are the largest by revenue. And if you include APPs, the largest by provider volume. And they're now in Texas, and he's looking at different areas to help independent rheumatologists. Do you think it's the mindset of a rheumatologist or a mindset of, I would say, a medical student who decides to go into internal medicine and then decides to do the subspecialty of rheumatology? Do you think that has a factor based on all of this?
I'm not sure our residents have enough exposure to that, although there are groups out there that are having meetings and doing exposure to the residents and those in their fellowships in order so they know all their potential. Now, Dr. Solomon's wonderful. I had the opportunity to meet him at Dr. Sue's conference. Arizona arthritis is very large and a pinnacle practice in the U.S. Most rheumatologists, though, are 2 or 3 providers, definitely less than 8 typically. I don't think they have the big aspirations. And I think as those of us that have stayed independent have watched what's happening in different MSOs already over the last few years, a lot of what I'm hearing is some adversity to wanting to make that move, meaning sometimes that's not handled right, or it's overpromised, or it took away a piece of the administrative burden but created other challenges for the provider. So I'm not sure that we would all move that way. I do like security with that. I do think Dr. Solomon's plan of an MSO that could be larger would be more protective in nature, that we could all operate. But I also feel that sometimes when we grow too large and too many cooks in the kitchen, that it doesn't fit every landscape. And if you're talking about rheumatologists that have 10, 20 plus years already in practice, it's really hard just to shift gears on what a management service organization might dictate to them in the area of their daily life.
I just think we all struggle so much. And I say all of us, meaning those in healthcare management, because there's so many changes coming at us all of the time, such a large administrative burden. And you actually are working very hard beyond rheumatology to help create positive change within independent medicine. I know you have a group of about 24 providers in 11 different locations. What other specialties are you working in, and what commonality do they all share?
I'm working in internal medicine and a gastroenterology and dermatology. The core group of providers that I'm consulting with is typically rheumatology because that's what I live in every day. But there's core foundations of administration that we can all lean into to make a practice successful. I think what everybody wants to know right now is how to be financially stable. And that doesn't mean rich or wealthy, right? That means how do I make sure that I can pay everybody? How do I make sure I have a sustainable practice over time? And make sure that we're not creating too much redundancy, because I do believe redundancy is creating a ton of burnout. I mean, sometimes they're best practice and we layer so many extra layers of checks and rechecks that we burn ourselves out. Our staffs get burnt out. Where do we maximize and utilize staff in the right way? Where do we agree with third-party vendor participation to save us time? And so I think it's a different way of thinking about things. It is not uncommon for me to touch a practice that has not changed anything in 20 years, and they're drowning. They cannot keep up with the administrative tasks, the financial oversight that needs to occur, and then the operational changes that did not move forward with EHR and advancement and technologies that are there now. And so I think that everybody's got their ears perked up. They want to know, what can I do? What's achievable? What's affordable? How do I make sure that I retain my staff? HR is the biggest challenge post-COVID for everybody. Not just hiring, but just getting people to show up for the job interview. And then if they start, how do we train them the right way? We're having to redevelop job descriptions to match any advancements or technology that we're now implementing. These are the busy work type of items that not everybody's prepared for. And the providers just want to know, do they have staff they can lean in for that? Or do they have people that are showing up 9 to 5 and clocking in and out? And trust me, we need those people. But have you identified the right person in your practice to take you to the next level?
And that's what I look at, and I use this example all of the time. I love the book Winning by Jack Welch, who was the former CEO of GE. And he has this bell-shaped curve where he says, okay, you have the bottom 10% of a company, you have a middle 70%, and you have the top 20%. Your top 20% are your LeBron Jameses. They can play on any team. They will be stellar. They are the rock stars. They are the people who do not clock in and out, right? But they are the ones who take it to another level. They are your leaders. And then you have your bottom 10%. And if you get rid of them, you'll have a new bottom 10%. But these are the ones that drag everybody down, the negative people, the ones who don't show up. They call out all of the time. And you have your middle 70. And your middle 70 are the ones who, nothing against them, but you're right. They're the clock in and clock out. They are the ones who they have a family and they want to coach their kids' little league team. So you need to have these people, but that's your middle 70. I'm finding on the management side, Georgia, it is so difficult to find a top 20%. My top 20% now may not be the same, or maybe I've changed my thought process, or maybe it's because my clinic has grown so much, but my top 20% looks very different than it looked 10 years ago. What are you finding?
I think generational choices make a difference on how our younger folks feel about career paths and job change. And I'm not for that. I think, we always want to promote and support our staff. And I don't concentrate on the top 20%. I believe that's there, and I've been lucky enough to have that staff over the years, but the core of every office is that 70%, as you say. And for me, there's two things that I look for in that core, and I do some of this through my hiring practices. Do you like human beings? Because I don't want to employ anybody that doesn't like other humans, and I've had people tell me I'm a dog person. And so that's my first red flag. So we'll walk through the interview in different ways and case scenarios, but you have to like other human beings because we're mission driven, right? We're mission driven to the patient. If you don't like patients and you don't want to help, you're not going to be successful in healthcare, or you should not be, in my opinion. Number two, for all of my staff, no matter how well they're going to perform, I need them to know that effort is not negotiable for me. And so I will give the mission the opportunity, right? And the expansion if requested. I have a lot of people that have worked for me over the years that say, I will do the base and that's the most I can handle. And I say, cool, let's make this work. What I am working through with the majority of people over the last decades is change management, right? We got this very hard change management issue through COVID. I've never in my life managed fear. I manage my staff fear, the patient fear, the provider fear, my own fear. I don't ever want to do it again, but that was the biggest crash course in change management I could ever imagine. And so now when I look at change management on the smaller level, I thought, well, dang, I just did it. On a much bigger perspective, a much bigger challenge, I can do this. And so where do we move? So every single position always needs reevaluation. I listen to my staff when they tell me something is not working. I don't delay their requests. Just the EHR alone has about a 15% rate of noncompliance, or what I call destruction in the practice, where something is disruptive and they can't do their jobs. And I never want them to get in the habit of just clicking through an okay. I want to fix what's broken and making sure that they know that door is open for them. And so this is how I get buy-in. I don't want their blood, sweat, and tears, and I don't want their firstborn children. I just want them to make the effort while they're here in the practice. And I think that can lead to a pretty good relationship and well wishes if and when they should proceed to their next journey.
I don't know how you find time to do everything that you do, because you're also very involved in, I want to call it organized medicine. You're very involved in our National Organization of Rheumatology Management, and you were one of the founders of Rheumatology Access Network. Why do you feel that there's such a need to be involved in organizations like this? And why did you create RAN?
Well, I'm a founding advisor for Rheumatology Access Network, and it's because of the patient access. So for me, I was approached as they were building this organization as a network of biologic coordinators and access specialists to share information. So when I came into rheumatology 15 years ago, I joined National Organization of Rheumatology Management to figure out what the heck was going on. As I said, I have managed a lot of practices, but I had never managed rheumatology, and there were a lot of challenges that were unique. Just the acronyms were unknown to me, and I did not want to outwardly ask pharmaceutical reps what they meant. So I asked some NOR members. I joined and really quickly learned that the community of management is very important in the specialty. Volunteerism allowed me to learn even more and to network with other great managers such as yourself. And I think that sounding board is needed. We can get isolated inside of our small practice. We don't have boards and committee meetings happening. It's me, myself, and I. And so the NORM network has been critical for me, and I highly encourage any new rheumatology manager to join that association. Now, Rheumatology Access Network really focuses on keeping access open for your patients. So our providers have done the hard work for their patients. They've made it a drug choice that they feel is going to benefit the patient. All that disruption and time delay and prior authorizations is what this organization focuses on, how we can create best practices, share our success and our failures for others to learn from them, creating a playbook of all medications and access support for our patient. And my role in that organization is to provide additional resources and education for the members as they come along. I am willing to lend myself and my time to any association or organization that is going to help this specialty or any patient along their healthcare journey. Effort with no outcome doesn't mean a lot to me. So I'm important. And my Portuguese mother had a saying, "You rest in the grave." It sounds kind of more, but I never saw her sit down. And so that kind of just from growing up, settled with me. I'm okay working 8 jobs. I'm okay with working until 9 or 10 p.m. I'm okay with doing whatever it helps because I see the true effect that it can have. for my providers and my patients along the way. So I can't cure them. I cannot write that prescription, but I can make it happen.
Georgia, you always attribute your work drive to your immigrant mom, who is Portuguese. I'm going to tell you, though, I really think it's a blend. It has to be of just not cultural, but it has to be generational as well, because that's where I'm seeing a shift. We have a lot of immigrants in this country, and I don't see the work ethic and the drive that you put forth.
Well, I have a lot of staff that's multi-generational, and I don't see a lot of distinguishable differences. I do modify sometimes my relationship with them. Some people want a little bit more personal engagement or motivation. Others are like, leave me alone and do my job. But for me, I do feel it's generational because from an early age, say 4 or 5, I was my mom's translator. I wrote the checks in the checkbook. I helped navigate adult life for her until she learned the language and could drive and take care of more resources herself. So that's ingrained for me, that part. I'm a caretaker. I try not to call it micromanaging. I've tried to really work my way around from that. But I'm just here as a supportive person along the route for anybody. So patients, providers, or my staff, that's the role. Now, generationally, I don't want to attribute a label to anything. That's always got me in trouble in the past. I do think that there are good, hardworking people of any generation. Sometimes our challenge as administrators is finding the right one through interviewing and then hiring the right person, right? We make our best educated guess at the time. Things kind of flush out within the first 90 days or so. But I invest in the person that I hire.
I love your positivity. It is energizing. And so I want to wrap up on the positive of the one change. If we could create a positive one change within our entire American healthcare system, what would that be?
I would like to see the insurance companies not becoming the providers. Don't give us Mother May I. Let physicians do what they were educated to do. That is probably not going to happen. I live in the prior auth world. I'm one of the few managers that say, okay, I'll live with it because I can sleep at night when I receive the information that gives me the permission to provide a service. But I really don't know a way that the provider is going to get out of the way because the American healthcare system is funded in capitalism. And I'm okay with that. I am not a proponent of one health plan across the U.S. I don't think that would be good for our country, but I don't see where anything's going to overtake the financial piece of away from the payers and their decision making. But I do really encourage, and I will leave this on a positive note or positive to me, for those of you doing prior auth or asking for permission from a payer and they decline you, always make sure and give them a call. Ask for the NPI of the person who decided to decline the treatment, that your provider made a decision with your patient, and document that for prosperity's sake.
I think that's a great idea because you know what? It needs to be actually a doctor who is providing the care and allowing treatment for the patient as opposed to the insurer. So on that note, Georgia Bonney, thank you for joining me on Working Healthcare. If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. Connect with me on LinkedIn to keep the conversation going in between episodes. If you've got a question, an episode idea, or someone you think I should feature, send me a note at meredithhirsh.com. Thank you all for the 5-star reviews. They help more listeners find the show. New episodes drop every Tuesday. Subscribe so you don't miss what's next. Tune in weekly as we explore the inner workings of healthcare, because you can't fix what you don't understand.